We are live now, no?
Yeah. Good evening and a warm welcome to one and all. This episode of AKSHARAM, which is a combined webinar series by the Oxy Medical Education Committee and Foxy Medical Education Committee, focuses on basic concepts in obstetrics and gynecology with an intention to make the postgraduates understand everything about each topic thoroughly. This episode of AKSHARAM series is the episode 6, for which we have got an eminent teacher, Dr. Jayashree from Cancer Institute. Next slide. Now I welcome ask our President, Dr. Vijaya, Oxy President, to give the welcome address. Vijaya ma'am is a professor in HOD at ESI Medical College, KK Nagar, Chennai, and former director of IOG MMC Chennai. Her special interests are high-risk pregnancy, infertility, and laparoscopic surgery. And madam has lots of awards to her credit and publications. And madam is actually a very dynamic president who actually makes us do a lot of things, explore a lot of things. And, actually we have learned a lot from her. Over to you, ma'am.
Good evening, all. It's a pleasure to come and watch and learn every month this AKSHARAM series, and every month we are exploring which is good for the PGs and who will be the best teacher to teach that subject and that chapter. That is what every month I'll think. And this time, we all know the malignancy. Though we have only 4: vulva, cervix, vagina, endometrium, uterus, and ovary. All are unique in that way, and classification and treatment and investigations keep changing. When to do PET CT, when to do MRI, and whether to do CT or MRI, which scores over the others, what is the role of endometrial sampling, all those things, and especially endometrium, the classification and the E again and the molecular classification has really come up and makes us confused much more. And I am really sad this year it started, and the exam going PG should be thorough with the molecular classification. And this and none other than Jayashree. She is a dedicated oncology teacher. For us we have recently only I came to know about her through our CMEs, and I was really impressed the way she is so much what to say that that attachment to teach people, that is there in that inspiration to teach others. So I welcome Jayashree, and I welcome Kiran ma'am. Kiran ma'am is always our Foxy Medical Education Committee chairperson. She is always with us, joining hands, and all AKSHARAM from the beginning she is with us, and she is encouraging us to do more and more interesting and needed topic for the postgraduate students. Kiran ma'am, good evening.
Good evening, very good evening. I hope I'm audible.
Yes, ma'am. Yes. Yeah. Because Karpagam, can you just ask madam to say a few words, then I can introduce Jayashree.
Shahidi, put Kiran ma'am's slides, na? Madam, we'll start with the
Kiran ma'am's this thing, and then I'll introduce Jayashree.
Madam, prayer song and Oxy prayer.
Okay.
Go to the previous slide, Sahiti. Yeah. We'll start the program with a prayer song. Next slide. And we begin all our programs with our with lighting of the lamp. Next. Now I invite our Secretary Madam of Oxy, Dr. Geeta Lakshmi, to say the Oxy prayer. Madam is a UG and PG teacher for many, many years and Secretary of Oxy at present and Associate Professor at Government AKSHARAM Hospital, Stanley Medical College. Next, Oxy prayer.
Geeta is there?
Geeta Madam said she will join, Madam. Na join pani message pote nanu.
Okay, read the prayer.
I will say the prayer, Madam. Yes.
Yeah.
Thank you, God. In humility, we gather. In gratitude, we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and mom reborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you. Vijaya ma'am, you can introduce Kiran ma'am.
Let me have the pleasure of introducing my dear friend, Dr. Kiran Pandey. He's a chairperson, Foxy Medical Education Committee. From her, I got the inspiration of starting the Oxy Medical Education Committee and to start this postgraduate webinars from eminent teachers all over the world, India, and also planning to do from across the country too. And Madam is the chairperson, Medical Education Committee, and she is a professor and former HOD of GSVM Medical College, Kanpur, and she's a president, Kanpur Menopause Society, and is a president, UP State Chapter, AGOA, 2004 to 2026. And she has done lots and lots of research activities and awards to her credit. And over to you, Kiran ma'am, to say a few words about this webinar.
Thank you, Dr. Vijaya. That's my privilege and pleasure to be associated with Oxy. And really, I mean, when we first met, Vijay, it was a wonderful association is going on with AKSHARAM. So congratulate you for this AKSHARAM series again. And at the outset, I would like to thank Dr. Jaideep Tank, President Foxy, and Dr. Madhuri Patel, Secretary General, for giving us this platform and this opportunity to be with the PG students and teach these wonderful topics. Well, I again congratulate you for selecting this topic, very relevant and pertinent for the time, than endometrial cancer. And as you rightly said, this since this molecular classification has come, many of our residents who are not tuned to it. And in fact, if you remember the time when we were resident, that time we used to always think the endometrial cancer was the simplest one and which was in the management, considering the cervical cancer and ovarian cancer. But today the scenario has absolutely reversed with this classification and with these newer advancement which is coming. And the reason I think reason basically is that the reason basically is that there were many, when we were dealing with the pathological classifications, there were many intra-observer variabilities. Sorry. आपके क्या बंद कर दिया, क्या हो गया ये? Hello,
okay,
am I audible?
Okay. Yes, ma'am.
Yeah. So basically, many of the intra-observable variabilities there depends on the pathologist, how experienced the pathologist is that, and accordingly. and that depends on the management, and the prognosis will be depending on that. So there were various factors. Since this molecular classification has come, although molecular classification is not being done, I mean, like molecular pathology tests are not being done, but IHC is available at every place, most of the places. And with the help of that, we can definitely work out those 4 types, basically, which Dr. Jayashree will be talking, I know, and simplifying it. We have to basically find out that it is a pole mutant, very simple thing. If it is a pole mutant, we don't have to do extra treatment and extra advancement and support. But if it comes to P53, the management has to be very aggressive. So this is just in 2 lines. I just wanted to say, I mean, the intra-observal, that variation has gone, the management has changed, the prognosis can be detected. What you have to give in the post-operative, you have to give the radiotherapy, or you have to give chemotherapy, or you have to give immunotherapy, or you don't have to do anything else. So all this has become very precise. So this is part of the precision medicine. So this topic selection for the postgraduates is extremely, extremely important. And actually, I love this topic. I've been talking about it at various platforms since it has come. At first time, it was actually very confusing. But now I know the things have become set totally. And the residents also will take little bit of time to understand. But definitely, I'm sure with their young brain, they will be able to pick up better even than us. So once again, I just wish you all the good topic. And just by the way, Dr. Vijaya, Dr. Jaideep Tank is here in the Kanpur.
Oh,
because we are having a conference of
Oh.
WW NetCon Foxy conference.
We could have asked him to say one forward.
He is actually on the flight.
Oh,
he will be reaching on 8:30 p.m. Here.
He was here yesterday, ma'am.
But we are going to be with us.
Okay. No problem, Kiran.
So please go on. Thank you very much.
Thank you so much, Kiran. Yeah.
Thank you, ma'am.
Good evening, Kiran ma'am.
Yeah,
Nice meeting
you.
you.
Joined. Okay.
Yeah, I have joined and I am traveling and I was hearing to you.
I saw you online.
So nice to meet you, ma'am. And hi, Vijaya and Karpagam. And welcome, Dr. Jayashree. Nice to see you. And we are waiting for your class. Thank you so much. Thank you.
Now we'll go ahead to the main teaching session. The teaching session is about CA endometrium, and it's going to be none other than Dr. Major Jayashree and ma'am, Vijay ma'am, you can introduce Jayashree ma'am.
Yeah, Jayashree ma'am, you can all see onco, everywhere onco. She's an MSc, MS DNB, fellowship in gynec-oncology, MCH in gynec-oncology from AIMS. What else you need? All students, you must be really fortunate to have such a wonderful teacher. And she's a special interest in ovarian cancer, cancer prevention and cancer research. And she has got many awards from FIGO, Tian TSU Fellowship in Gynec-Oncology, ASGO 2015 Best Free Paper Award, ASGO 2018 Widest Travel Agent. You listen to her, then you will know why I selected her. Over to Jayashree.
Thank you, ma'am. Thank you for the kind introduction. Shall I start, ma'am?
Yes, yeah. Please.
And share screen. Yeah.
Can you see?
Yes, ma'am.
I thought I could start with the log here first, then gradually go faster so that it's easier to catch where we are in. And maybe all the time we may not be handling only molecular classification. We may be handling other situations. So it is better to have it as a complete set. So what is the effect of hormones on endometrium? Estrogen is like post-menses when the endometrial cavity is completely empty. Estrogen works like a fertilizer. It increases the layers of endometrial glands and stroma like a fertilizer. Then what is the effect of progesterone on the endometrium? The progesterone is like a moving agent. It moves the layers so that it maintains the thickness. Doesn't allow it to be too thick and doesn't allow it to be too thin also. So this is the effect of hormones on endometrium. We should understand this. Because the entire pathology, what we are going to talk from normal endometrium to malignancy is based on this. Say if this is a layer of endometrium, all are beautiful cells, evenly arranged and evenly sized, have a beautiful similar sized nuclei, then they look like this. Then when there is an hyperplasia, there's multiple cells, lot of cells, more than what you're expecting. The stroma gland ratio is maintained, but the cells are too many. Then it becomes hyperplasia. Can you see a naughty guy with the specs there? He's the one who is in ATPR. He doesn't look like the others. So when there is a layer of cells evenly distributed with one among them looking different, like few are like atypical, they become simple hyperplasia. Like as you see in the jackfruit, the stroma is normal. There is no invasion to stroma. These fruits are uniformly arranged in single layer, but there are many. In hyperplasia, there is multiple layers, multiple cells, but still they are behaving well. So when it comes to hyperplasia with atypia, what happens when complex hyperplasia? What happens is they're not in one layer; they are in multiple layers. Cells are in multiple layers, one above the other, one below the other. The glands are in multiple layers. The stroma becomes less. The cells becomes more, and stroma becomes less. As we see here, the stroma is more here, stroma is less here. So when the atypical cells are more, like rotten cells are more, rotten means the nucleus is not like normal. The cells are more, then they become atypical hyperplasia. So initially, the WHO had a classification in which the spectrum was like normal proliferative endometrium to simple hyperplasia. Simple hyperplasia may have those odd elements that are those atypical cells, and then it becomes complex hyperplasia. Here we see the stroma is less, but cells are still in layers. Then hyperplasia with atypia. Here you have multiple layers of glands and cells. Stroma is hardly there, and some atypical cells. They have bigger nuclei and they are in mitosis. They are not like the normal ones, uniformly small nuclei sitting over there. This is spectrum. So WHO classified them as simple hyperplasia without atypia, with atypia, and complex hyperplasia without atypia and with atypia. We all know this, and this is a very favorite question in the entrance examination. Like 1, 3, 8, and 27, or 1, 3, 9, and 27. We would have mugged up these numbers. But WHO made into two-tier system in 2014, making them as simply hyperplasia without atypia and hyperplasia with atypia. This is because in the same endometrium, some area may be without atypia, some area may be with atypia, some may be simple, some may be complex. So based on this, so classifying it into 4 tiers was very difficult. So they made it into 2 tiers, making them into without atypia and with atypia. So normal endometrium, without atypia, multiple cells, no atypical cells. With atypia, you can see in the closer picture that some have mitosis, some have abnormal size and shape nuclei also. So coming to the other way of classifying it, it is EAN classification, which came in 2000. It is based on combination of morphological parameters, accessible objectively or subjectively. It is recommended by the ACOG. The parameters in this, it is called objective parameters, are the D scores. The D score has glands to stroma ratio, glandular perimeter, and nuclear diameter. These are the D scores. So the subjective parameters are like glands to stroma ratio, cytological difference with adjacent endometrium, lesion diameter, and exclusion of mimics and cancer. So you have to remove them from the diagnosis. Then it becomes, sorry, I just move this cursor from the screen. I'm sorry. Yeah. So based on the D score, they gave it like benign lesion, intermediate lesion, and EIN. So most of us follow the WHO system, the 2-tier system of without atypia and with atypia. So the based on EIN system, we have 3 diagnoses. That is benign endometrial hyperplasia, EIN, and adenocarcinoma. It has only 3: benign or EIN or endometrial adenocarcinoma. 3 different tiers. So what basically we see in that? Architecture, cytology, size of the glands, whether they are like less than 1 millimeter or bigger glands, and exclude mimics. Like we have to exclude other overlapping criteria, like what is that? It's the secretory endometrium, which is pretending like an atypical hyperplastic epithelium or polyp, or it is a reparative endometrium, all these. And we have to exclude cancer also. So these are the main criteria in the AN criteria. So when we have a EAN classification, we have a EIN. When we say EIN based on these classification and scoring, then the risk is almost like very high. And they associated this with loss of PAX2 protein and inactivation of PTEN tumor suppressor genes and MSI and KRAS mutations. So the risk is 45 times increased over to progression to endometrial carcinoma within a period of 1 year. So coming to the risk factors, we know what does estrogen does, what does progesterone does to the endometrial cavity. So estrogen works like a fertilizer. So if there is an unopposed estrogen therapy, progesterone works like a moving agent. Progesterone controls, when estrogen increases the layer thickness, progesterone controls exactly how much it should be, like trimming it. If there is no progesterone, then estrogen becomes unopposed and becomes a carcinogenic agent. And tamoxifen therapy, because tamoxifen works differently in breast and differently in uterus. In uterus, it has estrogenic activity. If somebody have early menarche and late menopause, that is after 55 years, then they are repeatedly exposed to the hormonal changes, they are at risk, high risk. Nulliparity, PCOS, because there is chronic anovulation, diabetes mellitus, because of pro-inflammatory state, hypertension of unexplained reason, granulous cell tumors, because it has a tendency to secrete estrogen, Lynch syndrome, because there is genetic defects in MMR genes, which makes the endometrium prone for malignancy. So Lynch syndrome is not only for the uterus, it has other sites also for malignancy risk. Cowden syndrome, familial history of endometrial, ovarian, breast or colon cancer, increasing age, older than 35 years per se, and obesity. These are the risk factors for the changes and malignancy. So how do they present? Usually they present like AUB. AUB may be postmenopausal bleeding. It is a cause of postmenopausal bleeding almost in 5 to 10% of women. And sometimes they may come for a routine examination, for an annual medical examination, or a postmenopausal lady coming for a medical examination. We find atypical glandular cells in the pap and then we go on investigating. Or they are getting a scan and they find a thickened endometrial cavity. So they've been referred to gynec for a evaluation of endometrium. Or we just did a surgery for some other condition, like say fibroid, or she had a profuse bleeding, uncontrolled AUB, and it was incidentally detected in the hysterectomy specimen. All these are the most common presentations. So what you do pelvic examination. What you will find, maybe uterus may be even normal size. Uterus need not be bigger, or it may be just a bulky uterus. Don't associate a big size uterus with hyperplasia, because this pathology is only within the endometrium. It is not in the myometrium. So the size of uterus doesn't correlate, may not be correlating with the findings. So differential diagnoses are like, if you have a lady having a postmenopausal bleeding and you have a suspicion of endometrial hyperplasia. So what else can be there? There may be endometrial cancer per se. So any endometrial hyperplasia with atypia, the risk of underlying malignancy is almost 1/3, 33%. Or risk of progression to malignancy, we said almost 45% in 1 year. So endometrial polyp. So if you have a polyp, a diagnostic hysteroscopy can confirm it. There may be endometritis in postmenopausal women, which may be causing infection, bleeding, collection, and all this may mimic hyperplasia. So what investigations we do? We do an ultrasound, and then ultrasound is a basic triage investigation. Then going on with endometrial sampling, with endometrial aspiration, dilatation and curettage, or hysteroscopy guided biopsy, and going for biomarker study, which we don't usually commonly do. We come to a conclusion with ultrasound and endometrial sampling. What to choose among them, endometrial aspiration or DNC or hysteroscopic guided biopsy? The baseline is the routine office endometrial aspiration. The sensitivity and specificity are comparable to DNC, and in postmenopausal women, it is very easy and more comfortable to do an endometrial aspiration because dilatation is not much required like in DNC. And when you have a repeated negative endometrial aspirations, but patient is symptomatic, we can go for a hysteroscopy guided biopsy. So first triage is ultrasound. So when should you do an ultrasound? In a woman with reproductive age, when we are doing screening for a woman with PCOS, we have to do it in the early proliferative phase, that is day 4 to day 6 of cycle. If a woman is on postmenopausal, but see, she is on cyclical hormone replacement therapy, menopausal hormone therapy, then 5 to 10 days after last progesterone tablet, then we'll get to know what exactly is the endometrial thickness. Otherwise, we may get a pseudo thickness, that is, the ET may be more than what it's actually supposed to be. So interpretation is best if you're doing it in the early proliferative phase for a reproductive age woman, or in a postmenopausal woman, she is on cyclical hormonal therapy, 5 to 10 days after she has taken a progesterone supplement, progesterone tablet. For women who are not reproductive age group, who are not on any hormonal therapy, you don't have to have a periodicity, you can take it anytime. So in which section you should take it? Done in sagittal plane, where endometrium is the thickest. So if intracavitary fluid is present, thickness of both single layers are measured and sum is recorded. If endometrium is thickened asymmetrically, largest anterior and posterior ET should be measured separately. Amount of intracavitary fluid is measured at its largest measurement in the sagittal plane. What we are saying by this is, if fluid is there, then we have a issue in measuring. Then we have to go for both single layers and measure it, and sum is recorded. Say that if you go, there's a fluid here, the fluid there, measure separately. If you're not able to measure together and measure it together. And if there is an irregularity, say one layer is anteriorly thick here, one layer is posteriorly thick here, imagine a midline and separately measure anterior and posterior thickness and add them together, then you will get the ET. If there is intracavitary fluid is there, you should measure it where exactly it is the largest thickness. You should go for multiple planes, move your probe in multiple planes and find out which is the largest measurement and then measure in that plane. So qualitative assessment of endometrium, you can have a hyperechogenic, isoechogenic, or hypoechogenic endometrium. It may be uniform or non-uniform. Sometimes you find uniform thickness, sometimes you find it's irregular, sometimes you find cavities inside. It is linear or non-linear, as we see in the picture. Bridge and edge. How is it? Like how it is, like entire uniformly thickened, and how is the borders with it? Border with the myometrium is that? Is the line maintained uniformly or line is breached in some particular area? And endomyometrial junction, whether it is irregular, interrupted, or it is obscured by the mass. Synechia formation, maybe strands of tissue crossing the endometrium. Or if there is intracavitary fluid. And any abnormal vascularity, if you can find it. All this will be helping us to understand the endometrium. So what is the advantage of ultrasound is it's non-invasive, generally painless, no complications, and it is more cost-effective also compared to other imaging modalities. Coming to the disadvantage, it is not specific to distinguish between benign proliferation, hyperplasia, polyp, or cancer. It's imaging, it's not histology. So you won't be able to define what is the pathology, but you'll be able to see whether it is normal or abnormal. So when will you do endometrial evaluation? If a woman is having more than or equal to 4 millimeter of endometrial thickness and she's postmenopausal, then we need a endometrial evaluation if she is symptomatic. If there is endometrial measurements where ultrasound is 3 millimeters, but some amount of fluid is there, then also you should go for endometrial evaluation. Endometrium shows diffuse or focal increased echogenicity, that is heterogeneity. There's some areas are hypoechoic, some areas are isoechoic, some are hyperechoic. This difference is there, then you should evaluate for endometrial, what kind of endometrium it is. If it is postmenopausal bleeding, that is bleeding after more than a year of amenorrhea in non-HRT uses, or persistent uterine bleeding in HRT use, it is more than 6 months. Any previous amenorrheic women on HRT who bleeds without apparent cause, say, or putting them on HRT and she's bleeding without any cause, then you have to go ahead and evaluating for endometrium. And if there is an abnormal uterine bleeding in a woman more than 35 years, or any abnormal uterine bleeding in a woman less than 35 years, it is not relieved with medication, you are giving medical management and it's not getting relieved, then definitely you should not stop with the ultrasound, you should go ahead with the endometrial evaluation. So abnormal uterine bleeding, it's not always postmenopausal, it may be heavy menstrual bleeding or intermenstrual bleeding, irregular cycles, unscheduled bleeding while on HRT, or postmenopausal bleeding. You're just doing an imaging and you're finding out something is there in the endometrial cavity. All this may be the presentation. So why this happens? As we said earlier, it is estrogen. Estrogen is a culprit. When it is unopposed by progesterone, it stimulates endometrial cell growth and it increases the cell ratios. So estrogen may be even increased by BMI, maybe anovulatory cycles, estrogen secreting tumors, drug-induced, maybe some drugs which we are giving for estrogen therapy, or like tamoxifen in breast cancer survivors. Any condition which can cause immunosuppression and infection. Genetic conditions like Lynch syndrome, these are the predisposing factors. So coming to the management of hyperplasia without atypia, that is a good ones without any abnormal cells. So coming to the good ones which have increase in cell number but no atypical cells, endometrial hyperplasia. Here the risk of progression to endometrial cancer is less than 5% over 20 years. It is over 20 years you're talking about. So the reversible risk factors need to be identified. Like patient is obese, patient is having PCOS, patient is having bad lifestyle, and she's having a sedentary lifestyle. And all these are the risk factors. They can be advised and they've been brought down by lifestyle modification over time. Observation alone or follow-up with endometrial biopsies when the identifiable risk factors are reversed is a way to manage her. Inform patient about other choices for management. Like patient should be aware that this is a condition which is caused by what are the risk factors she's having, and she's having this, and what are the ways that she's managed. What are the possible ways of managing, like progesterone treatment in women who fail to regress on follow-up alone or symptomatic patients. Like you are given her a way of changing a lifestyle and you're asking her to reduce her weight, or you're giving a cyclical low CP for PCOS. With all this, if she's not getting regress, condition is not getting regress, then we can go for progesterone treatment. So basically, for endometrial hyperplasia, first it is like we have to be like a lifestyle management person, like address obesity management, identify the use of exogenous estrogen use, EPRT or tamoxifen use, identify estrogen secreting tumors and manage. Progesterone treatment will regress the rate to 89 to 96%. But if they have these risk factors persistently, then they will revert back to hyperplasia. So basically, just reverting the risk factors. If it's not working out, then going on with progesterone management along with maintaining the lifestyle changes. So observation only alone can even revert 74.2 to 81% of women to normal endometrium. So it is not that only medication can help. So even with progesterone, then getting back to the same condition is also almost 50 to 75%. So if you are giving progesterone also, then they should have a lifestyle management ways, and they should understand this pathology is recurring, and it's basically because of the way risk factors which she's already having. So what to choose? Whether to choose for LNG, IUS, or oral progesterone, or continuous or cyclical progesterones, or durations 6 months for histological reversal. So coming to LNG-IUS and oral progesterones, LNG-IUS as a is that once you put it, it is there. The patient need not remember the drugs every day, and the stress of missing a drug and stress due to skipping and getting a spotting on all these are there. LNG-IUS, the dosage release is on 20 mics, which is very low. Systemic dose is very low. So LNG-IUS is better than oral progesterones. Coming to which one to give, continuous or cyclical progesterones. By giving a cyclical progesterone, then it may not revert as good as like a continuous progesterone. So if you decide to give progesterones, then go for continuous progesterones. And how long you will expect? The patient says, I'll come to you, started medication, how long am I supposed to get this? So you can give them a guarantee that at least for 6 months will be there to revert to normal. If they are reverting back within 3 months, then they'll be more happy. If you say them like next 3 months, I'll see, then by next 3 months, they'll get dejected. They may not even continue the management. So in the first visit itself, tell them like it will take at least 6 months for the histology to reverse. And follow up with EA. For simple hyperplasia, don't have to go for EA every 3 months, because these are usually like the younger group, AUB less than 35 years, to keep on going with EA, chance of introducing infection and other complications are more. So we can follow up them with EA for every 6 months, because they are only hyperplasia, no atypia. So if you are following them up, and when you will release them from, say they become normal, should you tell them like, don't come back to me next time? It is not like that. You should at least have 2 negative biopsies, like one biopsy this 6 months, and after 6 months again, you should call her again, even if you're tapering the dose, to do a EA to know whether the endometrium is staying normal before you release her from the follow-up. Because they're not malignancy, they don't have to keep on coming. At least 2 negative biopsies are needed. So to review when AUB occurs, if they have any abnormal uterine bleeding, even within this period of 6 months of follow-up, or when they are negative and they're being followed up, they should come back to the gynecologist for maintenance. So treatment should consider baseline cancer risk, like medical comorbidities, presence of AUB, treatment factors such as response, tolerance, and complaints, as well as patient wishes. So what should you consider when you're treating these patients are like baseline cancer risk, medical comorbidities, presence of AUB, treatment factors like how she's responding, and is she tolerating the medication, and how good she is taking the medication, and what you want from us basically. When will you go for surgical management? Hysterectomy is not first-line management for endometrial hyperplasia without atypia. The indication for hysterectomy becomes progression to atypical hyperplasia during follow-up. You're treating her, but she's progressing to atypical hyperplasia. No histological regression more than 12 months treatment. You are just giving treatment, and she's finished family and she's not going for any infertility management. She's in infertility. Then it becomes a reason that not regressing by 12 months becomes a reason for indication of hysterectomy. And some patients are there, I don't want to do anything, I'll get hysterectomy now itself. Just tell them, like, at least for 12 months you be on follow-up with medication. If you fail, then we'll consider for hysterectomy. And relapse of endometrial hyperplasia after completion of treatment. You've treated her and she became normal endometrium and she comes back again with hyperplasia. Then you should consider this time whether we can give her progesterone, but we are more inclined to go for hysterectomy this time. And she's been treated and she's having persistent bleeding symptoms, especially when there is heavy menstrual bleeding. And patient is poor complaint. She's not coming for EA, she's not taking her medication normally, and she's not understanding her complications. She's not maintaining her lifestyle changes, and she's regressing in her histology. Then these are the indications for hysterectomy. So what is the extent of surgery? Should we preserve ovaries? Endometrial hyperplasia as a pre-malignant condition doesn't have any impact of ovaries, so we can preserve the ovaries. Route of surgery, lap versus open. For endometrium, the voting will be for minimal invasive. So lap is preferred more than open. Can we go for endometrial ablation? Endometrial ablation can be a treatment of choice if it is available in your center. But the problem is after endometrial ablation, following up the endometrial thickness, following up her symptoms, or doing a hysteroscopy, and all this becomes difficult. So we should understand all these complications. And some areas like the canu of the uterus or near the cervix, they may not be properly ablated. That area may become an item of malignancy later. So now coming to the management of the real problems like hyperplasia, atypia. Hyperplasia with atypia, unlike in simple hyperplasia, total hysterectomy becomes we consider total hysterectomy earlier because of the risk of underlying malignancy or progression to cancer. At least 1/3 have a underlying malignancy, and the risk of progression to cancer is almost 1/3. So what should be extent of surgery? Extent of surgery, at least hysterectomy. Ovarian preservation can be considered if you have a facility for frozen section and the frozen section confirm that there is no malignancy or it's very early stage endometrium, then we can go for ovarian preservation. Lymphadenectomy for an atypical hyperplasia is not indicated. It is only atypical hyperplasia. And if you don't see any gross malignancy when you cut open the uterus and when the pathologist says you can't see any malignancy in the frozen section, you can preserve the ovaries. And even if they have a malignancy in a small size, they will not be a candidate for lymphadenectomy. So we can be sure that by doing only hysterectomy for these women, we are not missing out on anything. So mode of surgery for atypical hyperplasia, again, is minimal invasive, either lap or robotic. So for endometrial hyperplasia with atypia, endometrial ablation is not at all an option because we know the risk of malignancy is almost 1/3 over a time, and already underlying malignancy risk is almost 1/3. So for these patients, giving an endometrial ablation will not help her because some area which is not ablated can cause malignancy. If the lady with endometrial hyperplasia have atypical hyperplasia, desirous of pregnancy, we should understand that she needs child and her health is also a priority. And we should explain her the risk of medical management. That is, the risk of regression with medicines may not be complete. And progression during management is also there. And risk of their underlying malignancy with only a result of atypical hyperplasia and histopathology is also there. All this has to be explained. And side effects of medication, like we are going to give a more dose than what we are giving in a simple hyperplasia. So medication may have some side effects. This also has to be explained. And the need for prolonged follow-up. It's not like giving medication for a month or 3 months that she's going to revert. That lady should understand that she's going to take this medication till the time she becomes normal. And more after that also, we're going to continue her follow-up for at least 6 months to be in the same normal histology. So coming to risk of ovarian cancer in this atypical hyperplasia is almost 4%. Risk of progression to cancer in stage 1 is 2%. Risk of metastatic disease and death is almost 0.5%. Say I'm not talking about atypical hyperplasia. I'm saying that in case atypical hyperplasia has underlying malignancy. So stage 1 disease, the risk of ovarian cancer, like having ovarian cancer along with it is less than 4%. And progression to cancer, if she's having a stage 1 disease and you're giving, which is not diagnosed by EA, we're thinking that it's only atypical hyperplasia and we're giving progesterone, and it is progressing from stage 1 is almost 2%. It's very small amount, but the woman should know. And we are thinking that atypical hyperplasia and giving progesterone, but then having an advanced disease like metastatic disease and death is almost 0.5%. So we should be sure that if we're going for a medical management, we have a thorough imaging, tumor markers along with endometrial assessment by histology. So what are the medical management options? They are oral progestins, LNG-IUS, aromatase inhibitors, and GnRH agonists. These are some of the options, but most commonly used are the oral progestins and LNG-IUS. Outcomes what you are expecting is like disease regression rate with medical management is 85.6% from various studies. And the relapse rate, that is, they become normal histology and they're coming back again with atypical hyperplasia, almost 26%. That is 1/4 of the women. How many of them had a live birth after medical management is almost like 1/4 only. So 26.3%. So when a woman is on medical management for an atypical hyperplasia, how will you examine? Like every 3 months they are coming. So detailed history of symptoms. They should have a menstrual calendar. The first visit itself, when you're giving a progesterone, advise them to maintain a menstrual calendar, asking them to write down for every day whether they're having bleeding or not, how many pads they're changing, is there any spotting and everything. Pelvic examination, imaging with transvaginal sonography, and endometrial aspiration every 3 months. For simple hyperplasia, we said 6 months. For atypical hyperplasia, at least every 3 months. And long-term follow-up with endometrial biopsies, every 6 to 12 months, still hysterectomy is performed, or she is going for a definitive management for infertility. Tailored approach based on background risk factors. Like she has other risk factors, then we have to manage them also. So when will you interfere doing medical management? Is failure to regress in 12 months? Or the progression to cancer, why not follow-up? Risk of relapse, which is high during the first 2 years. And if hysterectomy declined, further cycles of progesterone treatment can be attempted, but the lady should understand that this has a risk, more risk to progressive malignancy. So when we are managing a patient for atypical hyperplasia, we advise them to go to a fertility specialist for consultation to look for any other factors which hampers their fertility. Okay, so if they want to go for conception, they should at least have one normal histology before they attempting fertility management. What should they go for, ART or natural conception? Since the rate of relapse is very high within the 2 years, it's better to go for a modality which gives them early pregnancy. So preferably ART. Obese women should be encouraged to bring BMI less than 30, which will help both conditions like fertility and in endometrial hyperplasia. Coming to HRT and endometrial hyperplasia, systemic ERT should be avoided in women with uterus. So only estrogen-only therapy should not be given for a women with uterus. It should always be estrogen progesterone replacement therapy. If there is any unscheduled bleeding, they should come back to the gynec. They should be given, this warning should be given when they are given HRT in the first go. Sequential HRT, LNG-IUS, or continuous combined HRT, what are the way, which one to choose, which drug to choose, all these are very different, have different connotations when you're coming to endometrial hyperplasia. The choice of HRT depends upon the individual factors, like how obese, what drug to choose, and everything. We have to be wondering like how minimum we can give, which drug to give, all this should be taken care of. So if you are giving a oral estrogen, we can use LNG-IUS also for progesterone support. And if you're giving a drug, estrogen, it should be the minimum dose, and it should be for the minimum duration. So coming to the next group of people who already have beaten up by the breast cancer and they're taking tamoxifen to prevent recurrence. Tamoxifen works wonders in breast in preventing recurrence, but it has a very different action on uterus, that it is having estrogen agonistic effect on uterus. So the competitive antagonist effect on breast is the need of the hour, but the side effect is the patient has has risk of developing uterine cancers. It are not always uterine cancers. They can have hyperplasias, they can have polyps, they can have a fluid collection inside the uterine cavity, or the fibroids which were there silently before they can even increase in size. So risk of estrogen-induced side effects are increased with dose and duration of treatment. Women on tamoxifen hence should be on follow-up for endometrial status. So as the age is more, the risk is also more. Women who are in the reproductive age group, the risk is like 1.42. Then women who are more on the postmenopausal age, that is more than 50 years, the risk is around 5.33. So tamoxifen effect on uterus on a reproductive age group women, on a postmenopausal women, when we compare, the effect is bad more in women who are postmenopausal. So can we use progestins? when tamoxifen-induced hyperplasia is there, when you give progestin, good, it will revert the changes of tamoxifen-induced endometrial changes. But it may have worst effect on breast cancer. We don't know how much it can affect the breast cancer recurrence rate. So we need to discuss this with breast oncologists about alternate options. They can change the tamoxifen to letrozole or something which doesn't have a estrogenic action, or they can go for ovarian ablation as surgical. If symptoms persist, we can offer them hysterectomy. If there is a polyp in the uterine cavity, we just have endometrial hyperplasia. Rest of the endometrium is normal. So when we do when we remove the polyp and we do endometrial aspiration, how will you manage? Will you take the hyperplasia or ATP on the polyp or background endometrium? The background endometrial will decide the management, not the endometrium on the polyp. So if there's a polyp with a background normal endometrium, we don't have to do anything. Polyp has a background simple hyperplasia or atypical hyperplasia, we'll manage accordingly. So if background endometrium is normal, polypectomy is curative. So you can go to RCOG guidelines number 67, which gives a wonderfully like a flow chart how to manage endometrial hyperplasia. It's simple or atypical, whether the woman is of desirous of fertility or not, non-desirous, then go for hysterectomy, or fertility desire contraindicated. And women who are having simple hyperplasia, simple hyperplasia you can observe. For the atypical hyperplasia, you can go for oral progestins and LNG-IUS. Then simple hyperplasia, 6 monthly EA. For atypical hyperplasia, 3 monthly endometrial aspiration. And look for what changes are there. Is there any progression, regression, or static? And how long you can give the management? At least 12 months. So with this, every visit, you have to look for whether she's regressing or not. And side by side, you have to go for the lifestyle modifications like changing her BMI and asking her to be more physically active, so that the other factors also help in reversal of the endometrium. So now coming to the real problems and real villains that endometrial cancer. This is the extreme spectrum of endometrium change. We started with normal endometrium, endometrial hyperplasia, without atypia, with atypia. Now we are going with the endometrial cancer management. So how will we discuss epidemiology, risk factors, classification, diagnostic evaluation, and management? Why it is important today, why there is much of noise about endometrial cancer and its management, why the staging is changed. It is because it's increasing in number. It's the 6th most common cancer globally, and 2nd most common gynecological cancer globally, and 1st most common cancer in developed countries, and 3rd most common gynecological cancer in India. The cervical cancer remains the main problem in developing countries, and the countries are switching over. They have a cervix and breast, and countries which have switched to a developed status, they have breast, endometrium, and ovary, and less of cervix. So endometrium numbers will increase as the socioeconomic status of countries improve. So the incident trend shows that there is gradual increase in countries like USA, where there is increase in other factors for socioeconomic growth. So coming to Indian statistics, we have almost 17,000 plus women with endometrial cancer, and the death rate is almost 1/3, and 5-year prevalence is almost 53,000, which shows that the survival is better, and the death due to endometrial cancer per se is less. The death in endometrial cancer patients are usually due to comorbidities like cardiac or diabetes or hypertensive disease, which they have otherwise. So this graph shows how gradually the number increased over 2 decades. When 2003 it was 2.5, now it is almost like 6, like 5.5 in India. So even in our country, the number has doubled up over years, and the trend is towards increase only. There is no static numbers in the years. So what are the risk factors? As we said earlier, the same thing. We have a hormonal therapy, estrogen-only hormonal therapy, early menarche, late menopause, nulliparity, anovulation, and increased socioeconomic status, and family history of uterine malignancy, which is like Lynch syndrome. And all these together increase the risk of endometrial cancer. And even in obesity, the more the weight, more the risk. Like we have a BMI of 25 to 30, 30 to 40, more than 40, risk is almost 1.5, 2.5 to 4.5, 7.1. And for type 2 endometrial cancer, that is non-endometrioid type, which usually we think is not estrogen dependent, also increases when there is obesity. And hypertension, it is a metabolic disease per se. If it is not even associated with diabetes, also has a risk of 1.5. And pre-pelvic artery, maybe for bladder or rectum, also increases the risk of uterine cancer. And tamoxifen, as we saw, for estrogen an anti-estrogenic effect in breast when it is given. It increases the risk of endometrial cancer. The risk is more when it is given for postmenopausal women. So can we screen and prevent this? For average risk general population, there is no way you can screen it or you can prevent it. But for increased risk women, like women who are tamoxifen users, chronic anovulation, obesity, or HRT users, we can go on with screening for endometrial thickness. Women with high risk, like Lynch syndrome, they definitely need screening. So for average risk, what do you do? Like every woman should know at menopause or taking HRT, any bleeding after that, they should report to a gynec. Many women doesn't know that postmenopausal bleeding is abnormal. So educating them itself will prevent much of endometrial cancer. So any bleeding, discharge, or spotting, they should report to doctor. But no routine screening is recommended for average risk women. For women with Lynch syndrome, that is high risk women, they have a 20-fold increased risk of endometrial cancer, but not only endometrial cancer. In Lynch, you have risk of colonic cancer, you have risk of stomach cancer, you have risk of ovarian cancer, bladder cancer, uterine cancer. So it is a multi-system affecting risk factor. So for these women, the screening should not. I mean, it's not only for uterine cancer. It is for one. It's for also GI cancers. So when we say what is mutation, some are like somatic mutation, some are like germline mutation. Somatic are the one which happens in a cell which is not a germline cell. That is not a cell, egg or sperm related cell. That is somatic mutation. If it is happening in a mutation happening in a egg or sperm, then it is transmitted from generation to generation again. They are the germline mutation. So Lynch is germline mutation. It's carried from one generation to another generation. So the risk is very high when there is a family history of Lynch syndrome. So if there is a family history of Lynch syndrome, say you have find somebody with Lynch syndrome, then what is the screening protocol? Annual screening beginning at the age of 35 years, and screening annual hysteroscopy and endometrial biopsy. And if she finishes a family, then we'll go for hysterectomy DSO at the age of 40 years. If she's completed a family, whom should be screened for Lynch syndrome? So any endometrial cancer patient coming to us, all newly diagnosed women with endometrial cancer should be recommended systematic screening for Lynch syndrome. That's what Society for Gynaecology says. What NCCN says is if you can't do that, at least do for women who are more than younger than 50 years. With IHC, check for their MMR proteins and MSI. So the ideal is for every endometrial cancer, if not for everybody, at least women less than 50 years should go on screening for Lynch syndrome. So how this endometrial cancers are classified? This is a PG type question, PG entrance type question, like type 1 and type 2. We have endometrioid and non-endometrioid histologies. Endometrioid is the one which you most commonly see in the OPDs, like 80%. Non-endometrioid is almost 20%. Endometrioid are the one which are estrogen dependent. So you have a relative younger age group. Very old lady, far from menopause, are the ones who get type 2 endometrial cancer. So who have high estrogen, obese women, unopposed estrogen like PCOS, and all those women have type 1 cancers. For type 2, usually they may not be obese. They may be far from menopause, as I said. So precursor lesions are like AEH or EAN in type 1, like in WHO pattern or EAN classification. Type 2 cancers, like the papillary serous or clear cell carcinomas, they have a serous intraepithelial carcinomas. They are the precursor lesions. So type 1 cancers are usually good. That is, they are confined to the uterus when they are diagnosed and they are in the early stage of diagnosis. Type 2 tumors, even when they are presenting at presentation, like when they have bleeding at that time itself, they have an extrauterine metastasis and they are bad. Mutations in type 2 are the p53 mutation. That is, p53 is a guardian gene. Guardian gene mutation is there in type 2. So when they present itself, they have an extrauterine metastasis. So coming to the histological classification, 2014, you must be knowing that endometrial adenocarcinomas, mucinous, seromucinous, serous, clear cell carcinomas, and mixed varieties. So endometrioid stays one side and non-endometrioids are on the other side. So now the hot topic, the recent advanced topic is the molecular classification. Like why we have this molecular classification when we have a clear-cut advantage of histological classification is when we have a endometrioid carcinoma also, sometimes even with early disease, they have a recurrence, which we don't expect to happen. So when we started searching for this, we come to a conclusion like it is not a single disease, It is different tones are there, like different types are there in the molecular classification. Based on that, the behavior changes. So the traditional dualistic view, type 1 and type 2, is broken by the pole ultra mutated, MSI high, copy number low, and copy number high. That is, these are 4 TCGA types. So previously, we had the precursor lesions, like as we said, hyperplasia without atypia, with atypia, complex apiplasias without and with atypias. This risk factors also changed. SCIC term came into, these are recent advantages. So when we say that when the disease is localized early stage, most of them, at least 67% are locally advanced disease, localized disease. The localized disease, the prognosis for 5 years is almost 95%. Okay, when the disease is outside the uterus, the prognosis is bad. So when the disease is localized, 67% of patients who have a 5-year good prognosis, should we treat them all with adjuvant treatment? The radiotherapy has its own side effects and chemotherapy has its own side effects. Should we treat them all, or should we treat those who have a risk of progression to recurrence? Those who have a chance of progression or those who have a chance of having a recurrent disease? This question came because when we say localized disease and leave them without treatment, some record. When we over-treated, they had a side effect. So to know this, the molecular classification came into the topic. So the newer topics which we are into the stream, which is boiling now, are the hot topics are like molecular markers, LVSI, a new term in the classification. Among the surgery, MIS and sentinel lymph nodes. So one side from diagnostic side, one side from management side. So diagnostic side, we have 2 topics, molecular markers and LVSI. In surgical side, we have minimal invasive and sentinel lymph nodes. I try to make it a bit easy, though it is not so easy to understand unless you have patients to go through the papers, how they thought of choosing these 4 patterns. We have 4 types. Pole ultra mutated. What is pole ultra mutated type is polymerase epsilon domain. Hotspot mutation, if it is there, then it becomes pole ultra mutated. How much percentage of endometrial cancer patients will have it? Only 7% of them will have. What is ultra mutation? We know pole is polymerase epsilon. What is ultra mutation? It means if you have a gene base pairs, in a mega base pairs, if you have more than 100 mutations, that is extremely high mutation rates, then they become ultra mutated ones. Okay. So we say pole mutation is good. Pole ultra mutated type is good. So if somebody is having so much of high mutation rate, that should be worst, right? Why it is good? It is because when a cell has so much of high mutations, they produce a lot of new antigens, new proteins, because these genes are conveying a message to which protein to produce. So when there is a lot of mutation, a lot of chaos, so a lot of new antigens are produced. The new antigens attract more T cells. They themselves get caught by producing more new proteins. And that's how they are like killed earlier when they're coming back again. So even immunotherapy works better in pole ultra mutated types. So this one is similar to type 1 tumors. It is told Pete and KRAS mutations are there in type 1 tumors. This is similar to them. So how does usually pole ultra mutated types present histologically? They are high-grade endometrioid histology with superficial invasion pattern, but they have very good prognosis. You see, they are high-grade endometrioid, not low-grade endometrioid. High-grade endometrioid histology with a superficial invasion pattern. With high-grade, you are expecting them to behave bad, but they have a good prognosis. So this mutation, if it is there, they will not need any adjuvant treatment. Coming to the next subtype, MSI high, that is hypermutated tumors. We have number of MSI proteins. That is MLH1, MSH2, MSH6, PMS2, and EpCAM. Some work together, like MLH1 worked with MSH6, MLH1 works with PMS2, MSH2 works with MSH6, like that, they work together. So, if one gene is absent, the related proteins are abnormal, deficient in the IHC. So, MMR deficient proteins are there, condition is there, then they become MSI high types. What is the incidence? If you have 100 cases of endometrial cancer, we said 7 only will have pole mutation. So 28 will have MSI high. So MSI high burden is, what is a high burden? What is hypermutation? We said ultra mutation is more than 100 per MB. This is more than 10 per MB. Okay. So what kind of mutations are identified if you're going for genetic testing? Then you can find P10, PIK3A, PIK3R1, KRAS, CTNB1, and FGFR2. These letters may look new to you, but these are the genetic mutations. There are different ways of finding mutation. One is like you place an order in a commercial site. Say you order for something. That is the genetic information. What you get in your hand is a parcel, the material. That is the proteins. The same way, the site itself has a code, right? That is a gene material. So if you have a genetic defect, like you have ordered wrong thing, you can find out from your order itself, that is your genetic testing, or you can see what has come to your home, what you have received as a parcel. So both ways you can find out. Finding from IHC is something like finding out from parcel. Some mutation has already happened. There are some changes which is seen in the slides. That is the way that is what you see in the IHC. Do a mutation testing, but genetic testing, it is like going back to your Amazon account or whatever account you have and check what you have ordered and finding, oh my God, I ordered something wrong. That's what is called, and that is like going for a genetic testing. So you should not think like why there is something else there, something else here. You also got something here. So you can find out from the order where you placed, like Amazon account, or you can come back to your home and see what you have ordered and what has been delivered. So when you see in a slide, it is expression. Already something has been expressed in the cells. The proteins are either deficient or there. You can see the IHC marker. So going for genetic testing and then finding out what are the mutations are there, what kind of mutations are there. That is going back to the main account and seeing like what is happening. That is not delivery. That is from the source where you did the mistake. Okay. So in this, what histology you will get? Mostly endometrioid variants. Sometimes non-endometrioids can also be there. And in this, there are some histological findings. These are very important for those who want to write an oncology entrance exam. MSI has TLs, MELF invasion patterns, and LBSIs. The LBSI is more common with the MSI high. Tumor infiltrating lymphocytes are more with the MSI high. And MELF pattern is also the pattern of endometrial glands. That's also common with MSI high. So even pathologists can, to some extent, help us understand this maybe even doing IHC. There is a lot of TILs and MELF pattern and LBSA is there. Then we can retrospectively look for IHCs saying that MSI high pattern is there. So next is MSS, copy number low variations. In this, almost 40%, majority of them are in this one. In this, there is a low mutational frequency. And a lot of progesterone receptor expression is there, and they respond to progesterone therapy. And in this, most common mutations are CTNB1, KRAS, and SOX17 mutation. Next is copy number high. The incidence almost 1/4. Prognosis is worst. Low mutational frequency, predominantly serous histology. The serous histology itself is a worst prognosis. And the mutations usually which you see are TP53 and ERBB2 mutations may be there. Okay. So how can we find out when you have a patient with endometrial cancer? So how will you find out whether what to do, how to find out all these? So should we go for a genetic testing? Should we go for IHC? It involves both because we are checking for three things. We are checking for a pole mutation, we're checking for MMR mutation, we're checking for P53 mutation. MMR mutation has expression in cell. So if you do a IHC, then you can find out that P53 has absolutely good expression in cells. So if you do IHC, you can find out P53 expression in cells. But pole doesn't have cellular expression. So you cannot find pole by IHC. So pole mutation need to be checked by molecular testing. MMR and P53 can be checked by IHC testing. So it's not that one thing can even solve everything. If you can go for a panel which checks for a pole mutation, MMR mutation, P53 mutation, genetic thing, that's also possible. If you want to go for cost cutting, that you want to reduce the cost, then you can go for pole testing by molecular testing and MMR and P53 by IHC testing. So this is a chart which says that, like previously we have a risk stratification. We said these are the bad tumors, intermediate tumors, low risk tumors. This is the pattern which we initially followed for management of endometrial cancers. So how does this four testing, like P53, pole and MMR testing, has changed it? Like you see that the patient with low risk groups, the light blue color ones, the risk of P53 is very less. And pole mutation risk is high. And intermediate ones are the in-between color blues. They are more common in MMRs and P53 wild types, not in P53 abnormal types. So high risk groups, the one with dark blue shades, they have more of P53 abnormality. They have, or MMR abnormality. They have very little pole mutation abnormality. Okay, so this shows that what we saw, this is by retrospective study, getting out all the endometrial samples from the previous studies which has been published and checking them for the MMR, pole 53 mutations and finding out what is their correlation with the outcome. We already know the outcome of the patients by following them up. Now we know their molecular typing also. So now we're trying to put them and see. Our assumption that pole is good, MMR is intermediate, 53 is bad. Is that working on them? So there is a trial, it is advanced by the research study data. There is a prospective trial also, which is dividing the patients into their groups, like the standard therapy, like what we are doing now, and an experimental arm in which we look for these mutations and decide accordingly. The favorable ones are the ones which have pole mutation, whom we are following them with the, if they have favorable mutation, pole mutation, we can keep them on observation. And if they have MMR mutation, the risk is intermediate, and they can go for vaginal brachytherapy, small radiotherapy, not a complete dose of radiotherapy. And patient with the bad mutation, mutation, put LBSI, substantial LBSI, and FCAM or L1CAM mutations, they are unfavorable. Then we give them external beam radiotherapy. That is, radiation doses more. This trial is ongoing. So how does the things have changed? Previously, we used to do hysterectomy. Previously, in the sense, what we are practicing now in many centers is that we do hysterectomy, BSO, and we do lymphadenectomy for endometrioid cancers. And if they are non-endometrioid, say clear cell, papillary serous, or high-grade endometrioid tumors, or tumors with the deeper myometrial invasion or outside uterus involvement, then we do hysterectomy, bilateral salping oophorectomy, pelvic node dissection, along with it para-aortic node dissection and omentectomy for non-endometrioid and high-grade endometrioid tumors. This is what we do. Then how we decide the management for adjuvant treatment, that is based on what is the stage, what is the grade, how much of LBSA is there in the histology, like in the final histopathology, whether nodes are involved, whether ovaries are involved, whether any omental involvement is there, and all these will decide the risk factor, saying that whether we need adjuvant treatment or not. Now, with the idea about what we have, what is pole is good, MMR is intermediate, and P53 is bad, now we are trying to jumble up all these together and trying to put them into different risk stratifications. The low risk ones, we have 5 different risk stratifications. As you see in the slide, we have different shades: low, intermediate, high, and advanced metastatic disease. Okay. So low ones are usually observed. Intermediate ones are go for observation or EBT. High intermediates are the ones which go for external beam radiotherapy. High ones are the ones which go for chemotherapy, adjuvant chemotherapy, and with or without radiotherapy. Advanced and metastatic disease goes for chemotherapy followed by palliative therapy. So this is the spectrum, like from no treatment to complete chemotherapy to palliative care. Now we have one more features added upon. Like they are jumbling up now. Like I'll show you the next slide. Like low was stage 1A tumor. Low grade is grade 1. And no LVSI was the low in grade 1s. Now, what they are saying is, if you have a pole mutation, even in stage 2 tumors, that is, tumor has spread even cervix. If they have pole mutation, they are good ones. You can trust them and put them in low risk groups. Okay. And if a stage 1 tumor, low grade, and if they have a MMR mutation also, they come to low grade tumors. And next one is the one stage 1 tumors, deep myometrial invasion, that is 1B tumors, low grade, and stage 1A tumor, high grade, and stage 1A tumor, non-endometrioid, stage 1A only, but non-endometrioid, all these were intermediate. Now what they are doing is any stage 1 with MMR mutation, they are going to intermediate. And stage 1A, P53 also goes to intermediate. Stage 1A only, but they have P53 mutation, they go to intermediate grade. Okay. The high intermediates are the one which they have substantial LVSI and stage 2 tumors. High grades are anything 3 or more. And advanced metastatic, you know that they are more. And they have, when you operate, if you are not able to give a complete R0 resection or with residual disease, or if you have some tumors with stage 4B disease, then they become advanced in metastatic disease. So molecular classification, which was only based on the pathology, it is like how much of endometrium involved, how much of what is the grade, what is the LBSI, whether other structures are involved. All these are now considering the endometrial pattern also, molecular pattern also, and the stages are going up and down. Like if you have a stage 2 tumor with pore mutation, they don't receive any treatment because they're pore mutation positive. And if P53 is positive, even if they're early stage, they're coming down to get a management. Next thing is LVSI. What is LVSI? Lymphovascular space invasion. That is, tumor is going to the lymphatic and vascular channels. And this may happen accidentally also, like when we are handling a specimen, some amount of tumor tissue can just be pushed inside the vessels. This can be an accidental thing, or it may be a smearing of the tumor cells when they get taking a slide. So to know that, whether it is only an accidental thing or a substantial LVSI, they have defined it. Focal LVSI is defined as presence of single focus around a tumor. Substantial LVSI is one multifocal or diffuse arrangement of LVSI, or we have find vessels, at least 5 or more vessels with tumor, then become substantial LVSI. So with the previous slides, as I said in the POTEC trials 1 and 2, when they did study the risk factors with molecular classification, they also found that LVSI is also an important risk factor. So LVSI is another new player which is coming to staging. Okay, so patient who already got a treatment for adequate treatment for stage 1 patients who undergone a surgery and lymphadenectomy, as per the surgeon, patient is completely treated. Okay, the patient should not come back with many recurrence. If they go put them into the molecular classification, they found that the recurrence was more with patients who have a LVSI and P53 mutations. This is from the retrospective data. So these things have brought us to a stage where we cannot omit molecular classification and presence of LVSI. So whom should you do molecular classification now? Molecular classification is encouraged in all endometrial cancers, especially high-grade tumors. Okay, because the low-grade tumors, 1A, endometrium only confined or less than 50% myometrial invasions, grade 1 tumors, you can omit. But it is encouraged in all when it is possible. So if you have a low risk and intermediate risk carcinomas, you can omit pole mutation analysis, because low grade histology and low intermediate histology, you're not going to give anything. Already you're not going to give anything. So by finding out whether it's good or bad, also you're not going to omit anything. So if you're not affordable, then don't do pole mutation analysis for those who are low risk and intermediate risk patients. So now the 2023 classification brings in us to a stage where from 2009 staging, which was looking very simple, like you have less than 50% myometrial invasion, more than 50% myometrial invasion, 1A, 1B, cervix alone is 2, serosa and adnexa 3A, parametrium and vagina B, 3B, and node, pelvic node C1 and parietic C2, bowel bladder 4A, and 4B is metastatic disease. It was very easy to mug up, and it was being practiced till then. Now we have 3 changes, main changes in that. One thing is that what we spoke about, like pole mutation, P53 mutation, MMR mutation, they've also been introduced. Second thing, LBSI. I said LBSI has a significant role, so LBSI has also been introduced. Third thing is now it is more histology based, whether it is endometrioid or non-endometrioid, whether it's aggressive type or non-aggressive type. So 3 main changes. So 3 main changes incorporated into an existing system. That's why we are getting surprised, like how to mug it up and how to follow it up. But over time, I think we'll get more used to, because it's more prognosticating and it guides the treatment very absolutely correct. Where to go is very easy with the new staging than with the previous staging. So what you have in the new FIGO staging, we have 1A is disease limited to the endometrium. Like the previous one, we had disease 1A is less than 50% myometrial invasion, the endometrium, or myometrium less than 50%. Or non-aggressive types, low-grade endometrioid with invasion less than 50% myometrium, or no or focal LVSI. LVSI is not in 1A. LVSI just takes it up. So LVSI, no LVSI, no LVSI in 1A, you should remember for whenever you're writing. So 1A1 is confined to endometrium or endometrial polyp of non-aggressive histology. That is only endometrium, no myometrial invasion. Only endometrium, if it is there, maybe in endometrium or endometrial polyp, it becomes 1A1. But it should be one non-aggressive histology. 1A2 is, it may be involving the myometrium, but less than 50% myometrium. Hardly you should find LBSI, or if you find, it should be focal LBSI only, non-aggressive histology. Now 1A3 is one tricky thing, like a low-grade endometrial carcinoma is limited to the uterus and ovaries. That is, ovary also has come to stage 1 if you have a low-grade endometrial histology confined to uterus and confined to ovaries. The specific criteria is to say 1A3 when ovaries involved with endometrium. If all the criteria are fulfilled, then you can call it 1A3. Okay. So coming to 1B, again, non-aggressive histology, more than half of myometrium, and no LBSI. LBSI should not come in stage 1. Okay. Coming to 1C, we said non-aggressive, non-aggressive. So aggressives are where to put aggressive, you see. So put them in 1C. Okay. 1A1, 1B, you have not put aggressives. So you should see where to put aggressive. So you should put it in 1C. All C's are aggressives. So aggressive histology type limited to polyp or endometrium comes to 1C. And coming to stage 2 is 2A cervical stroma involvement by non-histological types. 2B, it is like all the LVSI miss outs in 1A and 1B come here to 2B. Like 1A and 1B, if they have substantial LVSI, they become 2B. So what to see? Aggressive histology with myometrial invasion. So C alone is the aggressive histology. You can remember this way. A, B are non-aggressive histologies. C is the aggressive histology. 1C is aggressive histology confined to endometrium. 2C is aggressive histology going to myometrium. 1A and 1B are non-aggressives, but no LVSI. 2A and 2B are also non-aggressives, but 2A is cervix involvement, 2B is LVSI with non-aggressive histologies. So coming to stage 3, the previously whatever was there still existing there, uterine serosa adnexa. Now we are completely separating them. Previously we told A, now we are saying A is ovary and fallopian tube, 2 to serosa, and parametrium and vagina is B1, and pelvic peritoneum becomes B2. It's a new one. Pelvic peritoneum is also new in this. Going to pelvic and parietic nodes is C. Previously also it was C, but now we have subgroups in them, micromets and macromets. Macromets are those which are seen even with the normal histology, more than 200 cells. Micromets are the one which has less than 200 cells. Okay. So now we have micromets also get introduced. So when they're asking you a question in the exam, asking about what are the changes of new endometrium staging in FIGO 2023, I get back again. First thing is we have the staging depends upon the histology. Previously, there was no change as per the histology. Now we have aggressive and non-aggressive histologies decide the stage. Second thing, LVSI or no LVSI, substantial LVSI or no LVSI decides the stage. Third thing, ovary can come to stage 1 if they fulfill the criteria. Third change. Fourth change is that we have pelvic peritoneum in 3B2, which was not included in the previous staging. Fifth change is that we know metastasis to pelvic node is C and parietic node is C2, C1 and C2. Now we have to classify them further into micromets and macromets. So these are the 5 major changes which you have in the new staging. 1 is histology, 2 LVSI, 3 pelvic peritoneum, 4 micromets and macromets, and 5 you have this aggressive histology types. And then added on to that extra you have the molecular typing. So when we said ovary involvement, there are 2 areas where in the staging you said ovary involvement. One is 1A3, other one is 3A1. Okay. So when you will say 1A3, when you will say 3A1, this is limited to low-grade endometrioid carcinomas. The histology should be low-grade. And there should not be any extensive spread of the tumor. How do you know there is no extensive spread of tumor? That is because we can tell this by the tumor is confined to endometrium or less than 50% of myometrium. That is very much within the uterus. not much of LVSI. There is no outside uterus metastasis. And the ovarian tumor is unilateral, limited to the ovary, without capsule or invasion or rupture. That is, ovarian tumor is also very early. If this fulfills all the 4 criteria, that is early endometrium, early ovary, no substantial LVSI in the endometrium, no additional metastasis other than the ovary, then it becomes 1A3. Any of this fails, then it becomes 3A1. So this is an expectation this year. Like, how will you become? How will you say it's earlier? I mean, how do you 2023? How do 2023 staging differ from previous staging? You should remember all the points which I have told. Like 5 from the histology, 1 molecular classification. So we know that the stage pole mutation and 53 mutations. We know stage 1A pole mutations. I mean, this is confined. Pole mutation once goes to stage 1A. And a P53 mutation goes to stage 2C. Whatever is stage 1 and 2, if its pole mutation is there, irrespective of how much of myometrium is involved in 1 and 2, they go to 1AM pole mutation. That is this the way you have to write it down when you document it. And if P53 is involved, it becomes even early stage become 2C. Stage 2C, molecular P53. That's how you should document. So pole is good, P53 is abnormal. So how do they test it? We do testing for pole mutation first. Pole is positive, they go separately. Pole is negative, then they go for IHC for MMR and P53. MMR positive, then go separately. MMR is negative, then they go for P53 testing. P53 testing, P53 positive, it goes to one side. If none of them are positive, they become non-specific mutation profile. So we get 4 types: pole, MMR, P53 abnormal, and non-specific mutation. So if you have more than one, okay, on the lighter note, how to analyze them? Like pole, if we said pole is like good mutation. And many of you, those who are from Tamil Nadu, at least would have seen this movie Vikram. I hope so. Because many of my colleagues, like those who from Tamil Nadu also didn't see. So I got disheartened when I put this picture. I hope you all know this movie. So we here, like, everybody has a weapon. Like hero also has a weapon, and negative roles also has a weapon. So pole mutation, though it has weapon, it is hero. It is good. Now you have MMR mutation. It is like a villain. He also has a mutant. I mean, he's also mutant. He's also a weapon. P53 mutation, he's also a weapon. So all are mutations only. So which is good one? Pole mutation is good one. Though it is also having weapon, it is a good mutation. MMR mutation is intermediate. And P53 mutation is bad. So if multiple things are there. So when there is hero there, who will win? Hero will win. Pole mutation is there, and MMR mutation is there, and P53 mutation is there. Then pole only decides how it will work. Okay, look, hero decides like how the movie will go. Same way, pole mutation decides how the prognosis will be there. So if in multiple classifiers, pole is there, P53 is there, pole is there, MMR is there, then pole, if it is there, the outcome is good. In case pole is not there, only MMR mutation and P53 mutations are there. Both are bad. Then which one will be deciding? It is MMR mutation. In the movie also, who takes more screen time? MMR takes more screen time. P53 comes later, the last scene only. The same way, P53 mutations are second carrier mutations. That is, whenever there is a mutation which is damaging the cells, and there are so many damaged cells, there are some mutations which come as secondary mutations. So P53 mutation comes as secondary mutation with pole mutation or MMR mutation. So P53 mutation is a second mutation. It's a carried vehicle mutation. On the way it has come. It is not the cause of it. It has come as effect of the already existing mutation. So P53 will not decide the prognosis. Pole or MMR only will decide prognosis. So all 3 are there, or any 2 are there. If pole is there, it is a good prognosis. If pole is not there, MMR and P53 are there. P53 is a carrier mutation. It comes late. That's why MMR mutation decides. So you can remember this way. These are the most confusing, most dramatizing changes from the previous classification. We've just gone from slides to molecular classification. We've just gone from slides, deep into the slides to molecular classification. We're seeing the slides in different angle now to classify the person. Maybe we will need to go through this staging every time when we have an endometrial cancer patient. We have to put circles around whatever it is fitting into. Then we'll remember it better, at least for initial some time. So coming to the surgical part, we have minimal invasive surgery and sentinel lymph node surgeries. These are the hot topics in the surgical side. So what is preferable in endometrial cancer? Endometrial cancer, minimal invasive surgery is a preferred approach compared to open. We all know when it comes to cervical cancer, the LAC trial, the trial which abandoned cervical, minimal invasive surgery in cervical cancer, said that the prognosis of patients who are undergoing a minimal invasive surgery is bad in cervical cancer, wherein studies done for endometrial cancer does not show any change in survival outcomes for patients who are undergoing surgery for endometrial cancer with minimal invasive route. And second reason for going with minimal invasive route is many of the patients are obese, the wound-related complications, post-op hospital stay, wound management are more with open surgery than in minimal invasive surgeries. When the patient is obese, the size of incision also goes bigger, blood loss becomes more, duration of surgery becomes more, post-op hospital stay becomes more, rate of infections becomes more, need for blood transfusion becomes more. So open surgery is not preferred in endometrial cancer patients. The preferred surgery for endometrial cancer patients is minimal invasive, wherein the preferred modality for cervical cancer is open, because the LAC trial has showed that the prognosis with minimal invasive surgery is worse when compared to open surgery. For endometrium, I'm telling again, we have enough evidence to say that minimal invasive is better than open. So what amount of surgery we will do? We said that we can do hysterectomy alone, or hysterectomy with PSO with alone, or hysterectomy BSO with lymphadenectomy, or hysterectomy BSO, pelvic and para-aortic lymphadenectomy, hysterectomy BSO, pelvic, para-aortic lymphadenectomy, and omentectomy. Whom should you choose what? Like patients who are stage 1 disease and non-endometrioid, confined to uterus, less than 50% myometrial invasion, small tumors, you can do hysterectomy, BSO, and pelvic node dissection. But inspection of the common iliacs and para-aortic node is mandatory, because sometimes the nodes can be there in the common iliac and para-aortic through the fundal lymphatics. So it is not that you do hysterectomy, BSO, and pelvic node dissection alone and stay happy, that you should at least check for any enlarged nodes in the para-aortic and common iliac regions. If it is non-endometrioid, like say clear cell carcinoma or serous carcinomas or grade 3 endometrioid carcinomas, or tumor is involving deeply into the myometrium, then you have to do hysterectomy, BSO, pelvic, para-aortic, and for the non-endometrioid histologies, omentectomy also, because non-endometrioid histologies, serous and clear cell carcinomas, they behave like ovarian cancer. That is, tumor takes sanctum into the omentum. Omentum behaves like a sanctuary for the tumor cells. So for clear cell and uterine papillary serous carcinomas, that is non-endometrioid histologies, omentectomy is advised. For those who have a deep myometrial invasion and those who have fundal tumors and high-grade tumors and non-endometrioid tumors, pelvic and para-aortic nodes also has to be done. Can we do vaginal hysterectomy? Patients who are not fit for laparotomy, then our old patients with prolapse who have endometrial cancer, we can do vaginal hysterectomy. Disadvantage of vaginal hysterectomy is that you won't be able to take out the ovaries, so assessment may not be complete, and you won't be able to, obviously, you won't be able to complete the nodal dissection. But it will give a symptomatic cure and it may guide in further management. The next thing is sentinel lymph node biopsy. So what is sentinel lymph node biopsy? That is, whenever there is a tumor, the tumor tissue goes out of the organ through the lymphatic channels, and they enter a particular lymph node first and then goes ahead to the other lymph nodes in the channel. So when coming to any tumor, say it may be uterus, or cervix, or ovary, or brain, or stomach, or any organ, the node which first drains the organ is called sentinel node. First node, sentinel is a guardian. The one which stands out first to guard us is sentinel ones. The sentinel lymph nodes, how to identify sentinel lymph node is, like you can't see a sentinel lymph node by naked eye. You can't see uterus and say this is the sentinel lymph node. You have to find a way to find out the sentinel lymph node. So there are two different ways. Either you can be a calorimetric method or maybe a dye and gamma probe methods. Like calorimetric methods, you can put a dye inside the organ and look for the nodal enlargement and take out the node. or you can put a dye which give fluorescence, so the color only, and then find out, or you can put a dye which and find out through gamma probe. The different ways of finding sentinel lymph node. So when you're doing a sentinel lymph node mapping, you just take out the first node which is draining the organ, maybe in the external iliac area or operator area, and then you can see the node cross section, or you can just send for final pathology and decide what to do it. Sentinel lymph node mapping has shown as a good way of controlling, reducing the amount of lymphadenectomy for endometrial cancer. And there's a trial called FIRES trial, FIRES, FIRES trial. This shows that sentinel lymph node, doing a sentinel lymphadenectomy is enough compared to systematic pelvic lymphadenectomy. What is that? It is like removing all the nodes in the draining area versus only the sentinel node. Both have shown a similar outcome, but only extra caution is that since you are removing a very less number of nodes, you have to go for ultra staging of sentinel lymph nodes. That is, you should longitudinally cut the node and then cut them into 2 to 3 millimeter cuts, bread loafing as shown in the figure, and see that either any mets or micromets is there in the node and find out whether the monodal metastasis is there. So when you're doing a sentinel lymph node, you should be careful that you have a facility for ultra staging is also there along in your pathology department. So there are different studies like FIRE study and many different studies which shows that sentinel lymph node mapping even in high risk endometrial cancer has a good outcome compared to when in comparison to systematic lymph node dissection. Why we are asking for limited sentinel lymph node only, not systematic lymph node dissection? As we all know, if you do all the lymph node removal, then risk of lymphedema and lymphocyst formation and delay in treatments are there. So if you do a sentinel lymph node, the side effects are less. Okay, so for patients low and intermediate risk, we saw in their table like which are low and which are intermediate risk patients. Sentinel lymph node biopsy can be considered. Patient with high intermediate and high risk groups, that is, if you have a say, if you know that disease has gone outside the uterus, enlarged nodes are there. In those patients, you don't do sentinel lymph node, do systematic lymphadenectomy. So should we do only laparoscopy? Robotic, which is coming up nowadays, has a similar outcome. Robotic is no different from minimal invasive surgery. It is better version of a laparoscopy. So in the spectrum of surgery for endometrial cancer, robotic has also shown as a good, comparable and good outcome when compared to open surgeries, reducing the surgical complications. It is a safe and effective alternative for open surgery in endometrial cancer. So coming to the take-home message, minimal invasive surgery is a standard of care treatment for early stage disease. If it's early stage disease, it is a standard of care. Endometrial cancer is ideal cancer for MIS among all the cancers. It is less invasive, reduced pain, fast recovery, and shorter in hospital stay. And the care should be to take the specimen en bloc, no morcellation, no cutting, no spilling of tumor inside the peritoneal cavity. And when it comes to robotic surgery, it is a feasible and safe alternative to laparoscopy. Is there a way to avoid lymphadenectomy in endometrial cancer? You've done a surgery and I said when you're doing atypical hyperplasia hysterectomy, lymphadenectomy is not mandatory, but we know some may have endometrial cancer. So whom can we avoid lymphadenectomy? There's a criteria called Mayo's criteria. As per the low risk are the ones grade 1 or 2 endometrioid with tumor less than 2 centimeter with no or less than 50% myometrial invasion. These are the patients whom you can avoid endometrial lymphadenectomy. Okay, because in this, the risk of a lymph node metastasis is only 1.4%. Okay. So why should we do lymphadenectomy then? We can avoid in some patients. We can do SLN. Do we need lymphadenectomy per se? Lymphadenectomy is not therapeutic. In the sense, if you remove more nodes, if you remove positive nodes, will it increase the outcome? No. It may not change the outcome. Patient may recur, patient can have a reduced PFS and OS, like patient who have not undergone a lymphadenectomy. But lymphadenectomy will help us understand what adjuvant treatment is needed. If lymphadenectomy is not done, we have done only hysterectomy and BSO. And we know the tumor is like, to what extent the tumor is there. Then we may not be able to completely stage the patient. If the node is positive, it becomes stage 3C. if you haven't done a nodal dissection, then she may not be in stage 3. She may still think that she's 1A or 1B or stage 2. So in 1A or 1B or stage 2, the adjuvant treatment is radiotherapy. When it is stage 3, when it goes to lymph node, it is behaving like a systemic disease, then the patient will receive chemotherapy also. So this chemotherapy will affect the outcome. This chemotherapy will improve the outcome and reduce the recurrences. So by removing the node alone, by the surgery per se will not change the prognosis. But surgery will help us to identify the clues to give chemotherapy. The chemotherapy will help to prolong the life. So lymphadenectomy, so in that way is needed. For patients who are less than 2 centimeters, grade 1 or 2 endometrioid and less than 50% myometrial invasion, we said we can avoid. Whom should you do lymphadenectomy? For patients who are having more than 2 centimeter tumors involving outer half of myometrium, grade 2 to 3, high risk histologies, any high risk histology, it is high grade endometrioid, a clear cell or a papillary serous, involving the cervix or adnexa. When the nodes are involved by imaging or when you're doing an examination, find that nodes are involved, pelvic node or parietic node, then these patients are the ones who are candidate for lymphadenectomies. So lymphadenectomy does not change OS or RFS. It has risk because of lymphadenectomy, but this will change the outcome by dictating the chemotherapy or radiotherapy, whatever we're going to give the treatment. So there are enough studies to say that SLN and systematic lymphadenectomy are comparable. So in patients with early disease, going for SLN is almost similar to going for systematic lymphadenectomy. But for advanced disease, patients with obvious nodes and disease spread deep inside the uterine cavity or outside the uterine cavity, going for systematic lymphadenectomy is advisable. So what should you give as adjuvant treatment for patients with C endometrium? We as surgeons know how to do surgery. Like we do hysterectomy, BSO, pelvic node and parietic node dissection. And in omentectomy, we know whom to do, whom not to do. That's what we are discussing now. And after surgery, what to do? Should we give radiotherapy or should we do chemotherapy? In radiotherapy, should we give one EBRT or that is external beam therapy or vaginal brachytherapy? There are different trials answering these questions. The trials in endometrium, most famous ones are the POTEC trials, 1, 2, 3, 4. The fourth is going on. And GOG 249 and GOG 258. These are the most famous trials. They show that in patients with high-risk histologies, that is more grade, more LBSI or advanced stage, patient benefits with the radiotherapy along with chemotherapy compared with radiotherapy alone. In another trial, they compared chemotherapy alone. Should we give radiotherapy and chemotherapy? They found that in advanced stages, when there is disease outside the uterus, then giving chemotherapy is very mandatory. And radiotherapy may limit the recurrences in the pelvis. That is, pelvic recurrences will come down, but chemotherapy definitely will increase the overall survival. So we saw the fertility sparing treatment in simple hyperplasias and atypical hyperplasias. Sometimes even we get patients with endometrial cancer who are diagnosed during infertility workup. So can we give fertility sparing therapy for these women? If you want to give fertility sparing therapy for women with endometrial cancer, look for these criteria. Well differentiated endometrioid adenocarcinoma on DNC. Confirm it by 2 pathologists before going on with fertility sparing treatment. Well differentiated in the sense grade 1 endometrioid adenocarcinomas. Disease should be limited to uterus only by MRI and confirm with the TUS and MRI. Absence of suspicions of metastatic disease or imaging. No suspicion even of any metastatic disease should be there. And there is no contraindicated indication to medical therapy or pregnancy. What is meant by that is there is no other risk factors for infertility other than endometrium. And you should counsel and take it in document that it's not the standard of treatment for endometrial cancer. The patient should very well understand that what we are doing is for her wish to have a baby. This is not a standard treatment of CA endometrium. So look for the criteria in histology, look for the imaging, whether it is limited to uterus, no disease outside the uterus. And third thing, histology, imaging, contraindications for the drug or any other infertility factors. Fifth one is counseling and documenting. This is very, very, very important when you're giving a treatment outside the standard protocol for CA endometrium. So what you will do, if previously itself we discussed whether to go for continuous or intermittent therapy of progesterones, it's only continuous therapy and endometrial sampling every 3 months, not even 3 to 6 months, every 3 months. You expect a complete response in 6 months. Okay. And if she has to conceive, then ask her to go for a fertility management with a negative sampling and keep her on surveillance in between the time when she's getting a she's out, she's getting a negative report, and before she conceives, keep her on surveillance. Shouldn't be like she gets out of the endometrium pathology surveillance, it just goes for fertility management. She should be on for surveillance for the endometrium again. And if the endometrial cancer is present for more than 6 months, then advise her strongly for a management. If it's not regressing, cancer is not regressing, it's not becoming any less histology, then advise her again. Every visit, the documentation should be done. That previous histology was this. You've been given treatment for progesterone therapy to revert the endometrium. This is what the status is. Our plan is to go for surgery or go for another 3 months of progesterone therapy or to go for conception, early conception. This should be documented in every visit. It's not that you examine, put on the findings and send her to the places. Every visit should have a plan of management which has been signed by both the doctor and the patient. So how much to give? In the previous chart, when we were talking about the management of simple hyperplasia and atypical hyperplasia, I forgot to tell about the dosing for MPA and magistral acetate. The dosing for simple hyperplasia is almost 10 to 20 mg per day. And for atypical hyperplasias, is 20 to 40 mg per day. That dose is a mosquito dose for endometrial carcinoma. Endometrial carcinoma has already gone out of the range of the spectrum in which we are talking about reversible molecular changes, cytological changes. So when you are managing a patient with endometrial cancer, the dosing of medroxyprogesterone acetate is 400 to 600 milligrams per day. I'm telling again, 400 to 600 milligrams per day. No less dose, no mercy on dosing. And magistral acetate, 160 to 320 milligrams per day. I prefer magistral acetate than MPA because the tablets are available in 40 mg tablets. So giving 2 tablets in the morning, 2 tablets in the night, or 4 in the morning, 4 in the night is easier compared to MPA, which is not available in such a high dose. She has to take a handful of tablets. So I usually give magistral acetate over MPA. And you can use LNG IUD along with it. JNRS analogs are in trial, but the books are mentioning it, but much to do with it. Not much to do with it. You can use LNG IUD, but LNG IUD will not reduce the dosing of magistral acetate or MPA. You have to give high dose, never less than any 160 mg dose for Megace for endometrial cancer, because it will not revert if you're giving a lower dose. And don't worry about the side effects. Side effects are not usually dependent on the dose. It's not like if you take 40 mg of Megace, you have bloating, and 80 mg bloating, or 120 mg 3+ bloating. It's not like that. If the side effects are not, side effects usually saturated with the high doses. So whenever we are giving this medicine, we don't get so much symptom when we're giving very high dose compared to the lower doses or intermediate doses. So if you give, how much to expect? Like patients every time ask, how much I have a chance of becoming normal? Say it is 50%. Okay, the chance of reversal is around 50%. Chance of pregnancy is 1/3, and chance of recurrence again after becoming normal is 1/3, and chance of complete response but not getting pregnancy is also there. The newer drugs like pembrolizumab and envatinib, these drugs are coming into play. These are immunotherapy drugs. They are coming into play because we know more of molecular typing and we know more of molecular response of tumors. The pembro is one drug which works on PD-1 targets, and the lenvatinib is another drug. These drugs have been approved for endometrial cancer. We saw in pole mutation, they are ultra mutated. They are good types because of a lot of neoantigens, because of mutation burden, and they respond to immunotherapy. This is the immunotherapy which we spoke in that slide, the pembrolizumab or lenvatinib with pembrolizumab. So take-home message is incidence increases in the changing lifestyle. Postmenopausal bleeding to be assessed initially by TVS and endometrial aspiration based on the TVS reports. Metastatic workup with MRI and CA-125 can help you understand extrauterine spread, but it is not mandatory when you are doing it. It's not a mandatory package also. Frozen section is required if you are doing restratification. If you are trying to omit any procedure, say you're trying to preserve ovaries, trying to avoid lymphadenectomy, then definitely you should have a frozen section report. Without having frozen section, there is no way of reducing the surgery. lymphadenectomy is not required in low risk. When I say low risk, I mean Mayo's criteria positive low risk. That is grade 1, less than 50% myometrial invasion, less than 2 centimeter tumors. SLN should be used rather than lymphadenectomy in early stage when there is gross disease outside the uterus and suspicion of nodal involvement. Then systematic lymphadenectomy is a way to go ahead. MIS to be embraced that some our skills, especially those who are practicing open surgeries, has to be improved over time to accommodate ourselves for the para-aortic and omentum dissection by MIS, because MIS has shown good prognosis and good post-op recovery when compared to open surgery. And fertility preservation treatment, explain the risk, follow her up closely, be aware of risk factors, close monitoring, then you can take up fertility preserving treatment. So way forward, the way today is molecular testing for all cases and in tailoring of adjuvant therapy. The best way is not to get endometrial cancer. So advocate lifestyle management, that is workup, good eating habits, exercise, weight-bearing exercises, avoiding carbonated beverages and going for real juices, and being physically active and mentally active. So propagate this to prevent endometrial cancer. Thank you.
Thank you
Yeah,
so
madam.
much. Yeah, thank you so much, Jayashree. I don't know, I'm really am I audible?
Yes,
Yeah.
yes.
At a loss for words. I don't know what to say. I'm thanking myself. I'm not a student anymore. Really, it is so tough to understand. And I think we need to study more and more about this molecular classification, the staging, how does it change? The involvement of the ovaries coming into stage 1, and again it comes into stage 3. It's all real problem. And also, there are a few questions I would like to answer before I can ask them question from the chat box. Jayashree, are you there?
Yeah, ma'am.
If there is a persistent bleeding on progesterone when a patient is on simple hyperplasia, should we do a sampling before taking a for hysterectomy, or we can straight away take for hysterectomy?
Ma'am, anytime you're taking a sampling and then taking for hysterectomy is better, ma'am.
Even though earlier it was diagnosed as simple hyperplasia, and
Better
she's
to
on
go.
progesterone.
If symptomatic, we should be definitely sure there is no progression with over time.
Okay.
And it becomes medically important. Patients feel dejected when the final histology comes as malignancy.
Okay. And the second question is, on the hyperplasia, if you are going in for fertility treatment, should we take an simple sampling or hysteroscopic sampling? Because she is going to conceive after the treatment for hyperplasia.
Yeah, I understand, ma'am. Like the recent what is it? Recent guideline says that every visit, like every 3 months, we should go for a hysteroscopic guided sampling, because some focal areas may be very abnormal than generalized. Even with Mirena, they're saying that go with hysteroscopy guided biopsy. But we are not practicing it routinely because it's not feasible. Like every 3 months going for hysteroscopic guided biopsy, at least an EA. And as we said, the normal should be at least 2 normals, even if she's going for a fertility management. And sometimes what happens is they get normal and we call them after 3 months. They are so enthusiastic to go and follow with the fertility management specialist. They don't come back and they don't even convey the message to the fertility specialist that they have to be on follow.
Okay, I understand. Yeah. The other one is, what is the chemotherapy for the endometrium? It is same platinum or?
I mean, we are blessed that Pakli Carbo is the same chemo for all.
Same only. Yeah, okay. So no problem.
At least
Yeah,
one
yeah.
thing we don't have a confusion.
Okay. And this frozen section.
Yeah.
Suppose we are going in for hysterectomy, and anyway we will send the whole uterus for frozen section, or how does it go? It's not like an ovary, where you
I have
take.
decided that if I have decided to go ahead with complete staging, like I have a uterine papillary serous carcinoma, clear cell carcinoma, high grade histology, I had a deep myometrial invasion and naked eye examination of a cut section, I won't send for a frozen section.
Okay.
If I try to tailor anything, say I don't want to do a nodal dissection, I want to preserve ovaries, definitely then I have to go for a frozen section, because
so
otherwise
the entire uterus will be
entire
sent
uterus has to be.
and we have to wait for 30 to 40 minutes for the thing to come. Yeah. The only
That
thing
may not be even conclusive. Still, the final histopathology can give us surprises.
I know.
But this will save us at least medical legally.
At the end of the talk, the only thing I understood is P53 is Surya and pole mutant is Kamal and MMR is Vijay Sethupathi. Now I am very clear on that. So nice, Jayashree. We can never forget even the students. Yeah. There are some questions in the chat
The
box.
chat box. Yeah. I will.
Karpagam?
Yes, ma'am, I'm there.
Hysteroscopy,
Madam,
whether
yeah, first question, what is the
disseminates,
significance of simple unilocular anechoic ovarian cyst in postmenopausal women? Please discuss about both cyst with thickened endometrium and cyst with normal ET.
I mean, I'll correlate the cyst with CA125 more than thickened endometrium or normal ET. I mean,
Yeah.
both can be because of a hyperestrogenic state. Like when postmenopausal women, anything more than even 3 centimeters is significant in cyst size. Like I mean, cutoff may be 5 for a premenopausal, postmenopausal women, but anything more than 3, you have to have a high suspicion for a malignancy. And endometrial thickness, though they say more than 4, we saw in the criteria itself 3 or more with fluid. So I'll go for CA125 first. Know what is a cyst. Okay, and characterizing a 3 centimeter cyst in a postmenopausal woman will be very difficult, whether it is simple anechoic cyst or it has any characterization. So I will go for a marker. And I'll keep her on close follow-up. Even if I say that it is normal, I'll ask her to come back for an imaging after 2 months to know what is happening with the cyst.
Yes, madam. One question related to that. So a lot of women we see, because in the atrophic uterus, the cervix is completely closed and we have thin endometrium with fluid. Does it carry any significance?
If thin endometrium is, that's what, if she's asymptomatic, we don't have to interfere with it. If
So
it
a
is
lot of people we
symptomatic,
see with the thin endometrium.
that's what I'm
See,
saying.
the thing, the measurement is also very important. I'm going to exclude the fluid and then measure, no, ma'am.
That's what I'm saying. If it's very thin endometrium and she's asymptomatic and fluid is there, don't have to chase out on all the fluids.
Yes.
Endometrial cavity. But if thick and fluid is there, above the cutoff, then we have to definitely evaluate her for that.
Yeah. One Dr. Tara wants, sorry ma'am, one Dr. Tara wants to know, are facilities for such molecular diagnosis available in Chennai?
Yes, yes. I mean, we have multiple labs. We have this facility for molecular panel in our own hospital, and we are like giving reports for other outside samples also.
Yeah.
Like pole mutation testing, if I am right, this comes for $6,000.
Yes.
And IHCs will cost their own charges. I think hospitals will have IHCs. Only pole may not be there. So pole, it's available. I mean, some give all together as a package, like pole, MMR, 53, and other genes also as a package. So it's available in Chennai.
Is it there in Cancer Institute?
Yeah, ma'am. We have, and we are taking samples from outside also.
Okay.
Dr. Dhanalakshmi wants to know, ma'am, is there anything like site-specific sentinel node dissection? Like if the tumor is on the left side, then the node on the left side will be removed.
Sentinel itself is very narrow gate. Okay, we don't have to be like more narrow on that. Like if you give a
yes,
like, I didn't explain about sentinel node method in because of the constraint in timing. Like we are injecting dyes either in 4 sites or 2 sites in the cervix, in the submucosally and stromally, and then we are looking for the dye on either side. So sentinel lymph node mapping is like you should look for the first node which is draining on either side, both right and left. It is not like you have a tumor inside the uterus, more on the right side wall or left side wall, you will see on that side. So uterus is a midline structure. So we have to see node for either side. If you have, both side glowing nodes, you have to remove. In case there is no glowing node, all the nodes are out.
Yeah. And for cost cut, Dr. Vijayalakshmi Kandasamy, Dr. Cost cutting, which molecular panel should we do, madam?
I mean, that's what we in our center, we are more cost oriented. So since we are working on with donations, so we do pole in molecular testing and IHC for MMR and P53.
What about hysteroscopy? Does it spread cancer by any chance?
No, hysteroscopy, studies with hysteroscopy, like doing hysteroscopy and then correcting peritoneal fluid and looking for malignant cells, has shown, say, some 7 to 8% of peritoneal fluid may have malignant cells when we do hysteroscopy for a malignant patient. But these cells have not changed the prognosis. Even when peritoneal fluid, when we do a hysterectomy, the FIGO staging says collect peritoneal fluid for cytology. Though it doesn't change the staging, there's a box which says that collect fluid and report it also. Maybe over time you may have some implication on that. So it's the same way when you're doing surgery, if you have peritoneal fluid is positive for malignancy, we're not changing the management. Peritoneal fluid positive for malignancy, as a standalone risk factor doesn't have a value.
That's the thing with ovarian cancer, no, madam.
Yeah, it has a value in ovarian cancer, but
Ovarian
not
cancer. That's the
endometrial
difference
cancer.
between this endometrium, because there's been a controversy for a very long time that you do hysteroscopy and the tubes are patent. The endometrial tissues just go to via the tubes into the petroleal cavity. There has been always been a controversy there.
Yeah, that's what I'm saying. Like the pressure in the tube, I mean, usually the pressure in the hysteroscopy is supposed to be lower than the pressure.
Yeah, that's the
risk
low
of
pressure.
spillage is supposed to be less. These are practically,
Yes.
I don't know how much we can measure the intratubal pressure and the intrauterine pressure and intrapetroleal cavity pressures and all this stuff. But even when there is a spill, the studies we have level 1 evidence to say, even when there is a spill, when peritoneal cavity fluid become positive, it is not changing the prognosis. So
that's very
hysteroscopy
true,
doesn't worsen the prognosis of endometrial cancer, unlike in ovarian cancer.
Yeah, that's we always say keep the pressure very low so that you have adequate distension to view the cavity. Make sure it does not have any vascular or a spread towards the tubes.
Yeah.
So keeping the pressure is low pressure is very important, madam. And
radiology finding in ovarian spread of endometrial carcinoma, will it be a solid mass or will it be a cystic lesion?
I mean, usually any meds to ovary usually solid.
Okay.
Like any meds.
What is the tissue taken for the molecular panel?
Solids. Any meds to ovary is usually bilateral. So even in endometrium,
synchronous tumors.
As we could take it as a bilateral solid tumors only. That's why specifically the classification for 1A3 says that it should be unilateral. It should be early stage endometrium, early stage ovary. It should be no the metastasis outside.
What is the tissue should be taken for molecular panel? Obviously endometrium, I think. Yeah,
when you have this molecular testing is usually done from the paraffin blocks. You can give fresh samples from the tumor itself, like we do both. Like when we are operating in our hospital, when the tumor is huge lot, like filling the entire cavity, and pathologists will not fight with me for taking a bit of it. I send it in the RNA later tube and send it to the lab. But when the tumor is very less, me scraping it may change the staging itself. Then I don't do such things. When it's not grossly big, I send it to the pathologist. Pathologist prepare the paraffin blocks, and from molecular oncology, the request for the representative blocks in which tumors are there.
We can put it in formalin, no problem.
No. If you're sending fresh tissue, then they have a separate fluid.
Okay, for molecular
testing. So if you don't have the tubes, then you just can ask the pathologist to give the representative blocks in which they have the tumor.
So we should not put the uterus in the formalin, is it?
No. It is prepared from the formalin fixed paraffin embedded.
Okay.
Blocks only.
Okay.
So it is no problem in putting in formalin. Yeah. When the molecular oncologist is requesting for a paraffin block, pathologist will choose. They know, like they label it, say E1 or E2, E3. They know which one has the maximum tumor tissue. They give it to them. From that, they elute the wax and then they choose the tumor tissue, and then do testing.
And how long does it take for the results, madam, for the molecular panel?
7 days to 10 days.
Yeah. And Dr. Manju, what is the management for asymptomatic women with no postmenopausal bleeding with endometrial thickness of 5 millimeter or 6 millimeter?
You can keep them on follow-up.
Yeah.
No need, even postmenopausal women also?
Yeah, we can keep them on follow-up.
Okay. See, madam, one last question.
We should at least do some basic screening for cervix and as a routine examination and keep people on follow-up.
Yeah. So my only concern is, are we doing? We have done an endometrial biopsy, hysteroscopy get an endometrial biopsy. Then, if the biopsy shows atypical hyperplasia, we do not know what is the risk of acral malignancy. 1/3 malignancy chances can be there. Yeah. Are we justified doing an MRI for all such patients?
MRI cannot help us. That's a problem, actually.
Yeah, that's a problem.
MRI cannot help. MRI, even with stage 1A endometrioid tumors, many times they won't be able to find out the myometrial invasion.
Yeah.
They say it's only confined to endometrium. The endomyometrial junction is very well preserved. But when it goes to pathologists, they will say it is like 50% myometrial invasion.
Yeah, it happens.
MRI cannot help us in knowing. Definitely not for hyperplasia or malignancy.
Yeah.
Still, MRI scores over CT, is it?
Yeah, definitely. For a uterine evaluation, MRI scores over CT. For if you know the disease is advanced, for a big cavity growth, then now you're chasing nodes and other areas, and CT can be better.
Yeah. This other one is fractional curettage. The terminology is gone nowadays. Yeah. But you are telling hysteroscopic or simple endometrial sampling. Are we missing the endocervical malignancy?
Pardon me, ma'am, I didn't get you.
Endocervical malignancy.
in fractional, earlier we used to take the endocervical sample, then dilate the internal os, isn't it?
No, ma'am. When you dilate the endocervix, I mean, when you go inside cervix, there is a tumor in the endometrium. Definitely, it will stay in the area. That's why this concept of going for a fractional curettage is gone.
Then how do we
When you're doing
diagnose
endometrial
endocervical?
aspiration, if you have an adenocarcinoma, it is not clear-cut endometrial adenocarcinoma, then IHCs can help us to know the origin, like endometrium or cervix. And imaging and IHC can help. By histology alone, we cannot find out. By
So
doing it alone, we cannot find out.
endocervical curettings does not have any value nowadays.
If there's a bulky cervix, we know there is a growth in the cervix. We can just curate the cervix and send it for histology and ask them whether it is endometrium or cervix. Because even endometrium can spread to cervix.
I know. Either way.
Stage 2. Stage 2.
Yeah.
So by doing a fractional curettage, if there is a carcinoma in cervix, it may be an ischemic cancer coming to cervix also.
Okay.
It is more common in Lynch.
See, both are adenocarcinoma. So, kiriyan male and the kiriyan. Male and the kiriyan.
This is the first time, Jayashree, we have lots and lots of questions in the chat box. That much of confusing chapter, that shows how difficult.
No. Is there a cutoff for endometrial thickness above which asymptomatic postmenopausal women must be subjected to endometrial biopsy?
Guideline says no. Guideline says no. Usually they present. And the other ways also, like when you have a 3 millimeters ET and very little fluid, and the patient is asymptomatic, I mean, patient is having mild spotting and recurring with spotting, then once our EA is negative, we thought it is reassuring, but they have become UPSC, very, very, very famous celebrity. I don't tell her name.
But we see a lot of even polyps at postmenopausal
more important than ET.
So even when we in postmenopausal women, many times we see polyps also, madam. But the biopsy of the polyp looks benign. So do they also carry some significance?
That's what I'm saying. They're not symptomatic. We don't have to chase them.
Symptomatic, yeah. So it's not symptomatic.
They are thick endometrium, and we are perplexed more than the patient. Then we can call them again after a duration of 2 to 3 months again to look for a TVS. Then repeatedly doing imaging.
Many times we have seen very white out thin endometrium, but a small polyp sticking.
Small polyp and having last patient whom I operated had only a 5 millimeter thickness. See, a breast survivor, not on tamoxifen. And she's 77 years old, fragile lady. ET was 4 to 5 millimeter. But they said there is area of polyp inside the cavity. So I felt like leaving her and allow her to go. But when I examined, I felt a kind of discharge is coming from cervix, which patient was not able to appreciate. So I did a EA, it turned out to be a Newton papillary serous carcinoma.
There are 2 more questions, Jayashree.
Yeah, ma'am.
Yeah. If hysteroscopy biopsy showed endometrioid or adenocarcinoma, what is the next line of investigation?
If hysteroscopy guided biopsy shows that, then we have to go for an MRI to know the extent of disease.
Okay. The other one is if the histopathology comes poorly differentiated and the pathologist can't point out whether it is endometrium or cervix, what is next?
I mean, when histology pathology says is poorly differentiated and she's not able to say endometrium or cervix, we have imaging, which shows where is epicenter, where is the bulk of disease, whether it is uterus or cervix.
IHC also helps, no ma'am? IHC also helps in situations.
Sometimes they don't give. CA is also positive, ER is also positive. Like
then it becomes a complete. Then you treat it as a complete adenocarcinoma.
Complete disarray can be there. That time, those times, this can help, like imaging can help. And there will be the third situation where it is completely distending uterus, completely distending cervix, and parametrium is also involved. Now we don't know it is uterine or cervix. Now the treatment becomes very simple. Like anyway, you're not going to operate it CTRT.
Yeah.
So give it to them, Cori endometrium, Cori cervix.
The concept of radical hysterectomy is not there in CA endometrium, is it?
Yes. Previously, when cervix was involved, we thought of doing a radical hysterectomy to give margin. So the problem is, like when you do a radical hysterectomy, the vagina becomes shortened. There is no parametrial tissue and healing becomes late. So when you're giving adjuvant treatment, you won't be able to reach the real area where the radiation has to reach. So if you know the cervix is involved, just give enough margin to give negative margin. Should not be a positive margin. Like if it is involving the cervix and performances, just go below that and take it out. If parametrium is not involved, don't go there. If one side parametrium is involved, just take out that parametrium. Don't have to take out the other parametrium in vagina. It is like tailored negative. I mean, you just have to do operate only for negative margin. That is enough. So that when you're giving adjuvant treatment, this is stage 3. Like parametrium is involved, becomes stage 3, and if cervix is involved, becomes stage 2. So stage 2 is going to receive EBRT. So all the cut margins are going to receive radiation. In stage 3, they're going to get chemotherapy. So you don't have to overdo so that you can't, I mean, adjuvant treatment is delayed or adjuvant treatment cannot be given.
It must be the last question. Yeah, PET CT. Someone has asked for PET CT. What is the role of PET scan?
I evaluate one stage higher. Like I, in the sense, oncologists evaluate one stage higher. If the disease is confined to uterus, if a scan says uterus alone, then what I will look for in MRI or CT is a nodal involvement is there, abdominal cavity involvement is there. If my pelvic node is involved, parietic node is involved, then I want to know next level. So in that case, I will prefer a PET CT. Other than that, as initial evaluation in say endometrium, there is no role for PET CT. PET CT per se in gynae oncology has a role when we are going to go for a accentration surgeries, or when we are going to go for a treatment for a recurrent surgery, a recurrent tumor. If you're going to go for a surgery, then PET CT has a role. Otherwise, hardly PET CT has a role in gynae malignancies. Or in case your X-ray shows, chest X-ray shows a doubtful lesion, you per se know by a clinical finding the parametrium is involved, pelvis is very bad, it is an advanced uterus. Now, then asking an MRI or CT abdomen, pelvis and chest, I will ask for a PET CT. It becomes cost effective.
Okay. I think one last question. After the radiotherapy, if they are going in for surgery, PET CT is a must before going in for surgery?
Which condition are they getting radiotherapy? I'm not getting.
Chemoradiation. This is mostly for cervix.
Maybe I think after downstaging the tumor and going for a surgery or a interval cytotoxic surgery.
Yeah.
NACT is there in endometrium. Like if you have a huge tumor, if you think the parametrium is doubtfully involved and nodes are involved or invading the vessel, you want to operate but not now, later, then you can go for a NACT and then go for like ovary. No NACT-RT. CT-RT is palliative in endometrium. If you're giving a radiotherapy in endometrium, it is palliative.
Yeah.
So doing a surgery post CT-RT is no, usually not indicated.
Even for CS cervix?
Even for CS cervix.
Okay.
We do see a surgery for post CT-RT in CS cervix, only centrally located, less than 2 centimeter tumors, parametrium is completely free, residual tumors post CT-RT, or it is a recurrent tumor, very central disease, we go. That's what I'm saying. This indication of PET CT is recurrent disease, we are putting a hand for surgery.
Response to assessment?
No ways. PET CT cannot help us in assessing response.
That is the only thing.
Yeah. No.
It's very, very nice, Jayashree. Thank you so much for taking a valuable time. I know how busy you are, and we have learned so much.
Thank you so much,
graduates. We thoroughly enjoyed it. Thank you so much for
There's so much to.
What are the areas I have not covered so that the PGs can read?
Yeah.
And I told Lynch syndrome is familial, but there are some criteria for Lynch syndrome. It's not like you do whom and all you should look for Lynch syndrome. There is something called Amsterdam criteria, Amsterdam 2 criteria, and Bethesda criteria for Lynch syndrome diagnosis. And second thing, hysteroscopy role, and endometrial pathologies. What else I didn't teach? Specific role of imaging in endometrial pathologies. These things I have not covered. These things needs to be learned separately.
No problem. We'll keep troubling you. Don't worry.
Okay.
Yeah. Batch of PGs keep coming, and we'll be troubling you.
Okay.
Thank you,
so
Jayashree. Thank you so much. Yeah.
Thank you very much. It was a marathon session and we really enjoyed. And my goodness, as madam said, yes, as technology advances, medicine keeps evolving every day, and now the PGs have to learn everything.
I know.
As practicing clinicians.
They are like starting with automatic gear only. We are only.
I know. Yes. Correct.
So we are growing 1, 2, 3, 4. They will straight away press only accelerator and brake. So they are not.
And in the exams, we are also learning because we need to update ourselves every day, and a lot of things have
Switching is
really come up in a
better
big
than
way.
switching up something
And
new.
one thing good about endometrium is diagnose early, treat early, and
That is
completely
prevent. I mean, previously
prevention.
when I
Yeah.
entered oncology, I used to think if given a choice, which one to choose among cancer, but we have to pray to God which one to get. I used to
See, endometrium is a very good
now,
prognosis.
now
So
I
many people are
ask
there,
for
madam.
it because endometrium is worse than anything. If it is early, it is best. If it is
Yes, yes.
advanced,
Early
it's worse.
diagnosis.
So
Prevention,
now I
primary
am praying
prevention.
God that I don't put on weight and don't get endometrial cyst. The first way is to prevent endometrium, then ask for any
That
malignancy.
again boils down to lifestyle factors.
Yes, it again boils down to prevention than talking so much
Yes.
about malignancy.
Yes.
Yes,
Thank you so much, madam. We thoroughly enjoyed the session. And I'm sure, I'm sure all the PGs must have also, even though they are a bit paranoid about how much to learn, but I think overall it was a very engaging session. And all your Amazon, Flipkart, courier service, your
Everything.
Vikram movie show, everything it actually makes us understand things much better. I now understand how this genetics and IHC is. Oh, I got the point.
When I find very difficult things, I go back to simple methods. I thought,
Yeah. That makes us understand very easily, madam. Thank you so much for the lovely session.
thank you.
Thank you, everyone. Thank you, Vijaya madam, Geeta madam, for the opportunity. And Kiran madam, I think has logged out. And thank you so much. And Jayashree madam, absolutely amazing session. And thank you all the PGs for joining in. And thank you, Sahiti from Shield, for the platform. They always helpful and always give us the platform for these academic sessions.